Namaskaram, dear friends. The Global Initiative for Asthma Control has come up with its 2025 update for diagnosis and management of asthma. There are around 20 updates, and I suggest you watch the video till the end where I've summarized them all. Starting with the guidelines, just a word about the basics of understanding these guidelines. GINA guidelines are given for management, diagnosis, and management of asthma in three age groups. First is less than equal to 5 years, second, it has classified as 6 to 11 years, and third is adolescents and adults. There are two treatment tracks. The first track shows the preferred medicine to be given, and second track shows the alternative medicine which can be given. ICS LABA means ICS formoterol for all practical purposes because this is the only long acting beta agonist which has a shorter onset of action and a very long duration of action. That is, it simulates both SABA and LABA. Track 1. In this track, ICS LABA can be used as both anti-inflammatory reliever therapy, that is on step 1. This means that this anti-inflammatory drug can be used as a reliever on an as and need on an as and when needed, and it can also be used as SMART. SMART is single maintenance and reliever therapy, that is a single inhaler being used both for maintenance, that is regular treatment, and even if exacerbations occur, the same inhaler can be used in increased frequency as defined by the GINA. This is done from steps 2 to 4. And finally, in track 2, there are two more types of relievers. First is a combination of ICS SABA, and second is SABA being used alone. The first update is addition of biomarkers. Biomarker, as we know, are easily measurable variables which can detect a disease early in its course. Two biomarkers suggested by GINA are blood eosinophil count, that is BEC, and fractional exhaled nitric oxide. Nitric oxide is produced normally by airway epithelial cells and in larger amounts by inflammatory cells. So whenever there is airway inflammation, for example asthma, the levels rise up and this can easily be detected in breath. Inflammation is of two types. Type 1 inflammation, which is driven by the T helper 1 cells, mediator being interferon gamma. It is a cellular response and is seen in inflammation against the intracellular pathogens. Type 2 inflammation, on the other hand, is Th2 mediated via Th2 cells, mediated via cytokines like interleukin 4, 5, and 13. It is a humoral kind of immune response and is seen in allergic and parasitic infections. Having a knowledge of this helps us in phenotyping asthma into allergic and non-allergic asthma. Now we know that asthma has several phenotypes and endotypes. Two main phenotypes are allergic and non-allergic. So the knowledge of this pathophysiology and this difference in types of inflammation helps us in determining the type of asthma, whether it is allergic or non-allergic. It also helps us in deciding treatment to be used. For example, biologics are useful in type 2 asthma. Jinnah has mentioned that their cutoff values and factors affecting in the initial diagnosis, role in phenotyping, the fact that higher the values, the higher the risk of exacerbation and poorer the prognosis, response to ICS formoterol therapy being independent of the value of these markers, higher value of these markers suggesting a better response to biologics in severe asthma. The second update is about the risk factors. Jinnah has always stressed upon three categories of risk factors which predispose a patient to severe exacerbation. These are the risk factors for exacerbations, risk factors for developing persistent airflow limitation, and risk factors for side effects of the medications. To this, Jinnah has added the assessment of type 2 biomarkers also while assessing the risk factors for exacerbation. The third update is addition of impact of extreme weather conditions which disrupts healthcare of people living with chronic illnesses. Mechanisms by which they do so is increased levels of air pollution, for example from wildfires, enhanced survival of respiratory viruses, and increased concentration of allergens like mold and pollen. Mitigation strategies include use of face masks to reduce PM 2.5 exposure during wildfires, sheltering in temperature controlled environments such as shopping malls, other interventions, for example, use of mobile phone alerts and automated health related weather alerts. PM2.5 or particulate matter 2.5 are small particles which are less than 2.5 microns in size, and their clinical significance lies in the fact that they penetrate deeper and predispose to exacerbations. The fourth and the most important update is the fact that a diagnosis of asthma can be made in less than 5 years of age based on three criteria. First is recurrent acute wheezing episodes or at least one acute wheezing episode with asthma-like symptoms between the episodes. No likely alternative cause for the respiratory symptoms except for maybe a concurrent viral respiratory infection. Timely clinical response of respiratory symptoms or signs to asthma medications, and this response should be seen within minutes with a SABA and within 3 to 4 hours after SABA and OCS both have been started for a more severe episode. Short-term response to SABA at home is seen within minutes as already said, and reduced frequency or severity of acute wheezing episodes and or symptoms between the episodes during 2 to 3 months trial of daily ICS should also be considered as a timely clinical response. If only one or two criteria are met, the patient should not be labeled as asthma, he should be labeled as suspected asthma, and follow-up should be continued to look for completion of the criteria. A personal or family history of allergic disease may strengthen the diagnosis of asthma, but it is not at all mandatory for it to be present. Any of the following features in a child 5 years or younger suggest an alternative diagnosis and indicate the need for further investigations. These include failure to thrive, neonatal or very early onset of symptoms, especially if associated with failure to thrive, which would suggest a more possible genetic cause, for example, cystic fibrosis. Vomiting associated with respiratory symptoms almost never seen in asthmatic patients. Continuous wheezing, recurrent stridor or seal-like barking cough suggesting some congenital airway anomaly like tracheomalacia or bronchomalacia. Failure to respond to asthmatic medications like inhaled corticosteroids, oral steroids or SABA, thereby indicating maybe fixed airway obstruction. No association of symptoms with typical triggers such as viral URTI. Focal lung or cardiovascular signs of finger clubbing which would suggest a cardiovascular cause. Hypoxemia less than 95% is also not a typical feature of asthma. The dictum is the younger the child, the higher the likelihood of an alternative diagnosis. Home management in these patients should be initiated with inhaled short-acting beta agonists, and medical care should be obtained on the very same day if more than equal to 4 puffs of SABA are needed in less than 4 hours, or if SABA is needed more than 3 times within first 12 hours. There is no compelling evidence to support the use of OCS treatment given by parents or caregivers, and parents should seek urgent medical care if the child is acutely distressed, is drowsy or lethargic or worsening despite administration of SABA, in which case it shows progression to moderate to severe exacerbation. In patients who are being managed at primary care or an acute care facility, Jinnah has changed the cutoffs for oxygen saturation. Here, oxygen, if needed, should be given with a target oxygen saturation of more than equal to 94%. Earlier, the figures mentioned for the same were between 94 to 98%. For moderately severe or severe exacerbations, Jinnah says that you must not use nebulized magnesium. IV magnesium though still can be used, but personally I don't remember having used nebulized magnesium ever during my practice, though IV magnesium sulfate has been used several times. In the diagnostic criteria, Jinnah has clearly explained that the terms variability in symptoms and variability in expiratory airflow are two different terminologies. Variability in symptoms is that seen over time and intensity. Diurnal variation, that is maybe for example worse at night or on waking. Symptoms triggered by exercise, laughter, allergens or cold air. Symptoms worsening after end exercise, and symptoms appearing or worsening with viral infections. Variability in expiratory airflow, on the other hand, means changes in the expiratory airflow as measured by FEV1 on spirometry or by peak expiratory flow rate on peak expiratory flow monitoring. These can characteristically be seen pre and post bronchodilator. For example, in a patient post bronchodilator spirometry or PEF, FEV1 increases by more than equal to 10% and or PEF increases by more than equal to 15%. Variability in expiratory airflow is also depicted by excessive variability in twice daily PEF over 2 weeks, increase in lung functions after 4 weeks of inhaled corticosteroid containing treatment. I have highlighted the values in children because we are talking about children primarily. A positive bronchial provocation test, that is fall in FEV1 of more than 12% of predicted or fall in PEF of more than 15%, and excessive variation in lung function which has a good sensitivity specificity but poor sensitivity. This is to be seen between visits, values being more than equal to 12% in FEV1 or more than equal to 15% in PEF between the visits. Jinnah has replaced the term expiratory airflow limitation with the term variable expiratory flow, as it was misunderstood by many as per the previous guidelines. This is the personalized asthma care graphic, which shows that at every visit a patient should be reviewed for the following, assessed for the following, and his therapy should be adjusted as per this. To this, Jinnah has added the consideration of biomarkers while reviewing the patient's symptoms, exacerbation risk, side effects, comorbidities, lung functions, and his satisfaction. At a personal level, that is on a 1:1 basis, treatment decision should be based on the preferred medication, patient characteristics of phenotypes, patient views, beliefs and concerns about his treatment, and practical issues. For example, for the preferred medication, whether the patient is using inhaler correctly or not, can they afford the medicine, how is their adherence, and if more than one inhaler is available to the patient for a particular medicine, then which inhaler has the lowest environmental impact. But at the population level, treatment decisions should be guided by efficacy, effectiveness, safety, and access, because these are used to formulate guidelines for the masses. Jinnah has retained the two-track treatment, the preferred track using ICS formoterol as the reliever and ICS SABA or as needed only SABA as the reliever in the alternative track, since ICS LABA is not yet available at all places. In the treatment figure for adults and adolescents at step 4, Jinnah has replaced medium to high dose ICS LABA with only medium dose maintenance ICS LABA, thereby stressing that we must minimize the use of high doses of inhaled corticosteroids also. Also, the referral at step 5 here. It should not be delayed wanting to see the response of add-on medications, for example, long-acting muscarinic antagonists and leukotriene receptor antagonists, before referring the patient to a further specialist for further workup. The dose of fluticasone furoate are labeled as low medium and medium high in place of low and high respectively, in order to avoid ambiguity when being compared with other steroids in this table. One must remember that this table is not that of a potency equivalence. That is, a shift from, say for example, medium dose of one steroid to another medium dose of another steroid can make the patient's asthma worse. So you should exercise great caution while interpreting this table. Phenoterol has been added to the list of non-recommended bronchodilators because of the high risk of hypokalemia and cardiovascular side effects seen with it. Other non-recommended bronchodilators include oral SABA and theophylline, anticholinergics in the absence of inhaled corticosteroid, even long-acting antimuscarinic agents, for example tiotropium, and formoterol also without inhaled corticosteroids because of the increased risk of exacerbations. This is so-called the flower figure of Jinnah guidelines, which guides a clinician as to how to choose an inhaler device for a patient. This should be a shared decision between the doctor and the patient or the caregiver. Jinnah says that the first step in this process should be selecting the preferred medication instead of choosing the preferred inhaler, as was misunderstood as per the previous guidelines. Action plan is that which needs to be followed during an exacerbation. So if a patient is on Jinnah track 1, that is using ICS LABA as the reliever, then whether he is at step 1, 2 that is using ICS-LABA as an anti-inflammatory reliever therapy only, that is on an as-needed basis, or whether he's on steps 3 to 5, that is he's using regular and ICS-LABA as a maintenance and reliever therapy. In either case, he should use maximum 12 inhalations of ICS-LABA in any 24-hour period. If a patient is on track 2 using ICS-SABA combination as the reliever, then whether he is on step 1, 2, 3 or 4, he must not take more than 6 doses of ICS-SABA or maximum 12 inhalations of ICS-SABA in any case during an exacerbation. If the patient is on track 2 with only SABA as the reliever, this is the most important scenario. Here on step 1, the patient should use SABA and take ICS whenever SABA is taken. At step 2, he must consider quadrupling the maintenance dose of ICS for 1 to 2 weeks. On steps 3 to 4, he must consider quadrupling the maintenance dose of ICS-LABA for 1 to 2 weeks and stepping up to a higher dose formulation of ICS-LABA if available. As needed SABA means taking 2 inhalations of SABA every 4 to 6 hours if needed. For severe exacerbations in a patient on any regimen, the patient should consider adding a short course of oral corticosteroids and switching on to track 1 if possible to reduce the risk of further exacerbations. As per the severe asthma decision tree, a definitive diagnosis of severe asthma should not be made even if a physician has confirmed the diagnosis, has looked for factors contributing to symptoms, exacerbations and poor quality of life, has optimized the management and has reviewed the response after 3 to 6 months, thereby labeling the patient as severe asthma. The diagnosis of severe asthma should only be made after step 5. That is after further evaluations have been done by the specialist in the form of chest X-ray or HRCT if still not yet done, skin prick test or specific IgE, ruling out other comorbidities like aspirin exacerbated respiratory disease or chronic rhinosinusitis with nasal polyps, obstructive sleep apnea, allergic bronchopulmonary aspergillosis, investigating the adverse effects, etc. A prompt has been added in this regard, once again to consider biomarkers and repeat them as and when required. Long-term safety and efficacy of biologic therapies will be reported up to 5 years but not beyond that, and hence shall be revised and published again as a standalone document as per the JINA 2025. So summarizing the salient updates, the role of type 2 biomarkers, particularly blood eosinophil counts and FeNO, has been stressed upon in the diagnosis, management, personalized asthma care, as well as in the assessment of patients for future exacerbations. Impact of climate change and extreme weather has been added. Diagnosis of asthma can be made in age group less than equal to 5 years. The role of anti-inflammatory reliever therapy with low-dose inhaled corticosteroid formoterol are underway and in patients who have symptoms less than equal to 2 days per week. Oxygen saturation target for children less than equal to 5 years has been changed from 94 to 98 to more than equal to 94%. The term variable expiratory airflow limitation in the previous criteria has been changed to variable expiratory airflow alone. In track 2, step 4 has been changed from medium to high dose of ICS-LABA to medium dose ICS-LABA. Daily doses of fluticasone furoate have been reclassified as low, medium and medium high. Phenoterol has been added to the list of non-recommended bronchodilators. The first step in choosing the preferred inhaler device is to choose the preferred medication which is best for the patient and then considering the environmental impact. In asthma, action guidelines have been provided for dealing with the doses of maintenance therapy of inhaled corticosteroid formoterol combination, inhaled corticosteroid SABA combination and SABA alone in track 1 and track 2s respectively. Nebulized magnesium is no longer recommended for management of severe exacerbations, and confirmation of diagnosis of severe asthma is done only after the patient has been worked up in a severe asthma clinic after the initial specialist assessment, that is at step 5. So thank you so very much for a very patient listening and watching. I hope you did like the video. If you did, please give a thumbs up and do share the video because it is going to be of immense benefit for everyone. Thank you and thanks a lot.